In 1909, that was a time when the first antibiotics was discovered. For next 100 years, we've used various antibiotics to cure patients. And at the same time, we have developed resistance to all these antibiotics because of various mechanisms. In the critical care unit, there are two kind of organisms which are very important. Among the gram positive, it is MRSA, and among the gram negative, Enterobacteriaceae and the non-fermenters. So, Dr. Abdul, I am asking you, what are the mechanism of resistance for Enterobacteriaceae, and what are the current drugs which are recommended for these organisms?
I've been wondering why Dr. Rajesh Chawla is specifically interested in gram-negative bacteria. And that's the right question, because we have plenty of antibiotics active against gram-positives. We have 5-6 antibiotics in the market against MRSA. So MRSA, the antibody resistance, is not a very serious problem as far as we are concerned. But the scenario is entirely different in the case of gram-negatives. We don't have new antibiotics against gram-negative in the immediate future for our clinical use. So when we discuss about gram-negatives, there are main two categories of gram-negatives. And one category is called as Enterobacteriaceae, that means bacteria living in the intestine of human beings. Enterobacteriaceae. Typical example: E. coli, Klebsiella, Morganella, Serratia, Proteus, Hafnia, and the big group. It's a big group of Enterobacteriaceae, most common E. coli and Klebsiella. On the other end, the main group is called as non-fermenters. Non-fermenters, forget about the definition, it's a complicated definition, but for ordinary people like us, non-fermenters means bacteria living in the environment, not inside the human gut, but in the environment, in the hospital environment. These bacteria like Acinetobacter, Pseudomonas, Chrysobacterium, and a big group of non-fermenters. Typical example: Acinetobacter and Pseudomonas. On one end, we have Enterobacteriaceae like E. coli, Klebsiella, and on the other end, we have non-fermenters, the environmental bacteria like Acinetobacter and Pseudomonas. The spread of these bacteria are different. The mode of spread are different, because Enterobacteriaceae live in the human intestine, and the non-fermenters live in the environment. You get non-fermenter infection from the hospital environment. The Enterobacteriaceae infection you can get from the community as well, especially in places where there is a lack of sanitation. That's why one of the reasons why the gram-negative resistance is spreading in India, because of lack of sanitation in many parts of the country. Enterobacteriaceae like E. coli, Klebsiella, with resistant gene, they spread in the water, they spread in the environment, and we all get it. On the other hand, the non-fermenters, they are not usually present in the environment. You can see in the environment, but they don't spread the way Enterobacteriaceae spread. Usually the patients get Pseudomonas or Acinetobacter from the hospital environment, from the room, from the equipments. That's the main source for non-fermenter. What's the mechanism of difference in Enterobacteriaceae and non-fermenters? The Enterobacteriaceae, yes, they all have penicillinase, they all have cephalosporinase, they all have extended spectrum beta-lactamase. Once the bug is extended spectrum beta-lactamase, penicillins will not act, cephalosporins will not act, aztreonam will not act, and many antibiotics like cephalosporins or aminoglycoside are also resistant. So ESBL, majority of the Indian gram-negative bacteria in tertiary care hospitals are ESBL producers. ESBL producing gram-negative bacteria is a typical example of multi-drug resistant gram-negative bacteria. That means drugs in multiple classes have become resistant. So ESBL is an example of MDR gram-negative bacteria, and I repeat, majority of the gram-negative Enterobacteriaceae in Indian hospitals are ESBL producers, otherwise MDR producing gram-negative bacteria. So how bacteria become MDR? They have extended spectrum beta-lactamases. And now extended spectrum beta-lactamase have started becoming carbapenem resistant. Not just started becoming carbapenem resistant, a good percentage of the Enterobacteriaceae in many hospitals are carbapenem resistant. And how do bacteria become carbapenem resistant? There are various mechanisms. In Enterobacteriaceae, the most important mechanism of carbapenem resistance is bicarbapenemase and enzyme. Bacteria produce enzymes to inactivate the carbapenem group of antibiotics. And there are two types of carbapenemase in Enterobacteriaceae that you should be aware. You should remember the name NDM, the New Delhi metallobeta-lactamase. Majority of the carbapenem resistant Enterobacteriaceae in South Asia, the mechanism of resistance is by New Delhi metallobeta-lactamase. That is the mechanism of resistance for carbapenem resistant E. coli or Klebsiella in India or other South Asian countries. But if you look at the scenario in America or the other neighboring countries in the West, it is not NDM1, it is called as KPC, Klebsiella pneumoniae carbapenemase. That is the commonest resistance mechanism for carbapenem resistant E. coli or Klebsiella in the Western countries. So what happened was NDM1 was originated in the Indian subcontinent, not just India but Indian subcontinent, and spread across the world, while KPC type originated in America and then spread across the world. So the mechanism of carbapenem resistance may be different in different parts of the world for Enterobacteriaceae, but basically they are all carbapenem resistant. So in Enterobacteriaceae we have KPC, you have got NDM1. But if you look at the scenario in non-fermenters like Acinetobacter or Pseudomonas, they usually have multiple mechanism of resistance. Pseudomonas or Acinetobacter can have porin channel mutation, so the antibiotic can't enter the cell, or there are efflux pump mechanism, there are beta-lactamase, so they have got multiple resistance mechanism. One of the important carbapenemase in Acinetobacter is called as oxacarbapenemase. Like NDM1, like KPC, the Acinetobacters have got oxacarbapenemase. Yes, some of them can have NDM also. They have got multiple resistance mechanisms, but oxa is one of the most common mechanisms in non-fermenter group of bacteria. Why do I say oxa, NDM or KPC? You may say, oh, they are all carbapenem resistant. Why should we differentiate? We need to differentiate even from a clinical perspective. The reason is the KPC type of carbapenem producing Klebsiella or E. coli in the West, they have got new antibiotics active against this bacteria. One of the antibiotics called as ceftazidime avibactam was marketed few months ago, and that is active against KPC producing E. coli or Klebsiella, because KPC belong to class A beta-lactamase. Serine belonging to a group of serine beta-lactamase, serine carbapenemase. Serine carbapenemase example is KPC, while NDM1 is a metallobeta-lactamase. You can remember New Delhi metallobeta-lactamase. NDM1 is metallobeta-lactamase, where KPC is serine beta-lactamase. Serine beta-lactamase. There are new antibiotics active against serine, but till today there is no new antibiotic active in the market, available in the market against the NDM1 producing E. coli or Klebsiella bacteria. Oxa, yes, is common in non-fermenters, but some of the Enterobacteriaceae, not some of the Enterobacteriaceae, some of the studies show that oxa is an important mechanism in Enterobacteriaceae as well. In India, many of the NDM1 producing E. coli, Klebsiella are also carrying oxa. They produce multiple carbapenemases, NDM1 plus oxa in Indian Enterobacteriaceae. That complicates the picture.
No, but won't the colistin would be effective against these in NDM1 producing Enterobacteriaceae?
Colistin is the only reliable antibiotic against carbapenem producing Klebsiella Enterobacteriaceae or non-fermenter. Majority of the isolates are colistin sensitive. The colistin resistance is a rare phenomenon so far. We have bad news. The colistin resistance have started appearing in many countries, and it is going to spread across the world.
And the TG cycline and minocycline, they are also emerging as a effective antibiotic against these oxa and carbapenemase producing bacteria.
Tigecycline is a good antibiotic, But the problem with tigecycline is that it's not useful for treatment of bacteremia. Tigecycline is good for tissue infections. You inject tigecycline, it diffuses into tissues.
And not effective against Pseudomonas.
And not active against Pseudomonas and a big group of other bacteria. It's not active against Proteus, it's not active against Pseudomonas. Pseudomonas is one of the big caveats of tigecycline. And tigecycline is not active alone as a single drug in bacteremic infections. And tigecycline is not licensed for hospital-acquired pneumonia, but the commonest indication in my practice for tigecycline is hospital-acquired infection. But I use it in combination with other antibiotics.
The minocycline, a new drug, although there are not many studies, very few small case series, and this drug is being promoted as a drug for the carbapenem-resistant Acinetobacter and Pseudomonas. What do you have to say about this?
Minocycline is a very promising antibiotics. Minocycline is related to tigecycline. If you look at the sensitivity data available from many countries, even I myself have conducted a study on the sensitivity of minocycline. If you look at the carbapenem-resistant Acinetobacter, the sensitivity data is similar to that of tigecycline. 75% of the carbapenem-resistant Acinetobacter in my center are sensitive to minocycline. So why can't we just do tigecycline? Why do we need minocycline? I mentioned earlier, tigecycline is not useful as a single drug in bacteremia, while minocycline is useful. Minocycline can be used either as a single therapeutic drug alone or in combination with other antibiotics for treating bacteremia. Minocycline achieves good concentration in the blood.
But I think it should not be given empirically. It should only be used as a definitive. Otherwise, I think this drug would be lost very soon.
Minocycline should never be used empirically.
Yeah, that's what.
Like even tigecycline, minocycline is a very important antibiotic in today's practice and in future, and it should not be overused. It should not be recommended for empiric usage. Should be only used when we have black and white printed sensitivity report in your hand.
You know, Dr. Ghafoor has been very active against this rising resistance, and he was a key person in coming out with a declaration which many of you may be aware, called the Chennai Declaration. So would you tell in 2 minutes about the Chennai Declaration and what you want to do in future?
When I talk about Chennai Declaration, I can talk for 2 hours but not 2 minutes. But in 2 minutes, yes, what Chennai Declaration is, yes, Indian doctors should know what Chennai Declaration is. Chennai Declaration is an initiative by medical societies in India to tackle the challenge of antimicrobial resistance from an Indian perspective. Chennai Declaration document was prepared by representatives of various medical societies and various governmental and non-governmental organizations in India. We wrote important recommendations on how to tackle the challenge in India. Chennai Declaration has been submitted to the Indian Ministry of Health. It's studied by the Indian Ministry of Health, and Chennai Declaration has become a very popular, not just a document. Chennai Declaration is an initiative. We are constantly communicating with the Indian government and other organizations who are active in antimicrobial resistance world. Chennai Declaration has become a very popular and important initiative in India. Chennai Declaration has played an important role in creating an attitude change on antibiotic resistance in India. I can say that before Chennai Declaration initiative, antimicrobial resistance was not a popular topic, or in other words, it was a topic with a lot of stigma. And Chennai Declaration changed that stigma altogether. Nowadays, everybody is discussing about Chennai Declaration. Everybody is so open about discussing about antibiotic resistance, and everybody is so open on antibiotic resistance issue. Hospitals are publishing the resistance data. Hospitals are publishing their antibiotic utilization data. That's a very important change. Has it made any significant changes at policy level? Yes, Chennai Declaration has been one of the important push behind the government bringing out the new over-the-counter rule to regulate the over-the-counter sale of antibiotic in India. How far this rule is implemented, some part of the country it is implemented, but overall the rule is still not yet implemented in the country because of many problems at the implementation stage. I can say that Chennai Declaration even helped the medical society to get the antibiotic resistance issue discussed in Indian Parliament.
Okay, so the resistance is a great problem. You know, from 1909 when the first antibiotic was discovered. Till 1988 we were discovering antibiotic, and now after a gap of almost 27 years, a new antibiotic, that also for gram-positive doxabacin. Is that right?
Dexobactin.
Dexobactin, that is coming. And I think we need to use the antibiotic judiciously. Only then probably we'll have few antibiotics left for our patients. Otherwise we'll keep on going back to the previous antibiotic, as we've gone to colistin, which was discovered in 1952. Thank you very much. Thank you.